Okay, I think we can get started.
Okay.
Looks like everyone's here. Okay. Hello, everyone. My name's Christine Pham, and I'm a clinical research coordinator with the Division of Population Science and the Department of Medical Oncology at Thomas Jefferson University. It's with my distinct honor to welcome you to tonight's Facebook Live event, Conversations about Cancer, Recovery, Research, and Reducing Your Risk. So our topic today will be a combination of lung cancer and smoking, which is the #1 risk factor for lung cancer diagnoses. We will cover information on lung cancer screening, prevention, treatment, research, resources, and information about smoking risks and smoking cessation. Today, organizations across the country are joining to celebrate the Great American Smokeout. Initially started by the American Cancer Society, the Great American Smokeout is a nationally recognized day encouraging people to take a step towards a healthier life by reducing or quitting smoking. Smoking remains the single largest preventable cause of death and illness in the world. No matter how long you've been smoking, reducing or quitting smoking greatly improves health, and chances of success increase with a good plan and support. In today's talk, we will hear from experts from the Sidney Kimmel Cancer Center, Philadelphia Department of Public Health's Tobacco Policy and Control Program, and a former smoker who utilized Jefferson's smoking cessation program. As our panelists share their knowledge and experience, please don't hesitate to ask some questions. You may leave your questions in the Facebook comments, and we will try our best to answer all of your questions during the live event. So to start today's Facebook Live, we would like to first introduce our amazing panel. So I'll call your name and go around the room, and then if you could just share a little bit about yourself with our audience. So to start off, Dr. Raj Singla, would you like to introduce yourself, please?
Of course. It's a real pleasure to be here today. I'm a medical oncologist at Sidney Kimmel Cancer Center of Thomas Jefferson University. I practice primarily in the Northeast, and I'm the thoracic oncology, or generally lung cancer, program lead there.
Great, thank you so much. Dr. Kwang Yi Wen.
Yes, thank you. It's really my pleasure to be here. And I'm Guang Yuwen, a behavioral scientist at the Medical Oncology Department, Thomas Jefferson University. I also direct our tobacco treatment program for our cancer center.
Great, thank you. Our community partner, Ronelle Nemchik.
Hi, thank you very much for having me. My name is Ronelle Nemchik, and I work for the City of Philadelphia's Department of Public Health and their Chronic Disease and Injury Prevention Program. And I specifically work with patients as well as staff in our city health centers providing tobacco treatment services.
Thank you so much for being here. And lastly, our Jefferson patient and former smoker, Carolyn Wenger.
Hi, it's an honor to be here with all of you. My name is Carolyn Wenger, and I started the smoking cessation program at the end of July, and I've been smoke-free since the end of August or early September, and I'm very grateful for that, so thank you.
That's amazing, congratulations.
Thank you.
Alrighty, so the first segment of our talk today is going to focus a little bit about what lung cancer screening is and how you can get screened for it and what are the treatments for lung cancer. So Dr. Singla, could you start off by telling us exactly what is lung cancer and are there different types of lung cancer and what potentially causes lung cancer?
Absolutely, we'll attack those in order. And Carolyn, I think almost nothing makes me happier than hearing that somebody quit smoking. It just puts a huge smile on my face. So great job and keep up the good work. So as far as what is lung cancer, so cancer is really more of a category. We tend to think about it like it's one disease, and it's really much more than that. So if cells don't, they grow when they're not supposed to grow. they don't die when they're supposed to die, and they go places they don't belong, growing into things close by or spreading to places far away. And if you check those three boxes, then we label that as a cancer, or a malignant tumor if there's a mass or something in the body. And lung cancer is simply cancer that develops within your lungs. And just like any other organ, your lung has different types of cells that perform different jobs. You have lining cells in terms of the lungs, ones that produce mucus. You have connective tissues holding everything together. And any of those cells can become cancerous. And so that does give rise to different sort of types or different flavors of lung cancer. I think the biggest divide that people kind of hear about sometimes, friends, family members, the news, and whatnot, would be small cell and non-small cell lung cancer types. The reason they made that distinction a long time ago is because there's a huge disconnect in terms of how these diseases behave, how they're treated, etc. Because it's kind of weird to say, like, this is Steve, and then literally everybody else is not Steve. Like, there's a lot of types of this and just one type of that. So as far as small cell, non-small cell, that's kind of the biggest divide. Small cell is a more aggressive, cancer that we generally see more in people who've smoked for a very long time versus non-small cell lung cancers. And certain types of cells you'll see in smokers. Other ones you'll see most commonly in people who've never touched a cigarette in their life. And that certainly does happen. So there are different types, and they arise for different reasons. And I think that gets to that last portion you asked me, which was, if I'm remembering correctly, and what can cause lung cancer. Is that right, Christine?
Yes, that's right.
Okay. So as far as causes, I don't think it's going to be too surprising to anyone. I think it's fairly well established in 2022, soon to be 23, that cigarette smoking is probably the leading cause of lung cancer, both here in the US as well as worldwide. That's not to say there can't be other causes of lung cancer. As we said, some individuals who've never sort of touched a cigarette before can develop a type of lung cancer, generally a type called adenocarcinoma, the gland cells of the lungs. And these mutations basically develop in the cells that cause them to go haywire and disrupt kind of their normal programming. And that leads to development of that type of cancer. You also have other occupational hazards. So when asbestos was being used a lot more in insulation, fireproofing, building, ships, that sort of thing, there were a lot of patients who developed mesothelioma lung cancer as a result of that. And there are other environmental toxins, fine particles, other things. And that's why people who work in certain jobs or conditions are recommended to use a respirator, masks, other things like that. You don't want to be breathing in fiberglass or, fine particles, sawdust, things like that, and certainly toxic chemicals and other things as well.
Great. As a follow-up, and you kind of already started to talk about this, but are there things that people can do to lower their risk or to prevent, getting lung cancer? Other than the using, protective equipment when they're working in these, environments. And
Right. And again, if we're looking at the entire pie, that's a pretty narrow slice. As far as that doesn't mean it's not important, but from a population standpoint, if you were going to do one thing to reduce the number of cases every year of lung cancer and lung cancer deaths, it would be, not smoking if you don't, and quitting smoking if you already do. That is, by and large, the majority of patients that we see, and particularly in our region within the Philadelphia and greater Philadelphia area.
Great. So moving on to how you can get screened for cancer, or for lung cancer specifically, what are the screening criteria and what does the screening look like?
Absolutely. So I think it's no surprise to anyone that we had excellent tools already for screening for colon cancer with colonoscopies, stool tests and things, mammograms for breast cancer. And we knew that smokers got lung cancer incredibly disproportionately higher rates compared to non-smokers, not even close. Despite that, they did studies looking at x-rays and other things like that for years, for decades, and none of them really demonstrated that you saved lives by doing those in the way that mammograms, colon cancer screening, other things can. And finally, several years ago, relatively recently, there was a very large clinical trial that was done across the nation, the National Lung Screening Trial. And that was really the first time here that we were able to sort of prove that you could save lives. And what they did is a CAT scan. So a CAT scan, computer-assisted tomography or CT, it's also referred to, it's a lot of x-rays, basically. If you took a bunch of x-rays and lined them up like slices of bread, you can make a loaf. So this is giving a lot more detail than an x-ray would. And as a result of that, it's very sensitive and it can detect very small tumors before they have an opportunity to become really aggressive cancers or to metastasize or spread to other parts of the body, which lung cancer does quite commonly, especially when it's detected kind of too late. So when caught early, this can be, can be treatable, can be, quite curable in many cases. So this study proved that this could lower your risk of dying of lung cancer by about 20% roughly. And there's some other studies that have been done since that time in other countries, other places, that show about the same numbers or even potentially higher than that, maybe closer to 30% or so. So as far as, I guess the next part you had mentioned was as far as screening. So who is eligible, who can get screened? So the people who are at the highest risk. In terms of false positives and false negatives, no test is perfect, all the time. So you want to take a group of individuals that's going to be at higher risk of developing lung cancer. These guidelines were just changed not even a year ago to make them a little bit more inclusive and, get more people screened. And in particular, opening up the guidelines now say that anybody from the age of 50 to 80 years old and anybody who has smoked a total of 20 years, 20 pack years is what they call it. So that's the equivalent of smoking a pack a day for 20 years, 2 packs a day for 10 years. You can kind of do the math yourself, but these are the people that are eligible now. So 20 pack years, age 50 to 80. And the third part is you need to either still be currently a smoker or have quit within the last 15 years. If it's been more than 15 years, you're 90 years old, you quit smoking when you were 30, you're probably good. You're probably safe in that case. And it doesn't mean you can't develop it, but it's a much lower risk population. So these are the three sort of things that we look at in terms of who's eligible for the screening program and who's not.
Thank you so much. So let's say a patient is eligible and they come in to get the CAT scan. What happens after screening?
So hopefully you get a phone call saying that everything looks great and you go about your life. But, these radiologists are going through, these are doctors that are trained to just look at x-rays, MRIs, CAT scans, and they're looking for small sort of masses or tumors within the lung. And if they see something that looks suspicious, and I think a lot of women who get regular mammograms kind of have experienced this before, just because they see a tiny spot doesn't necessarily mean that somebody has a cancer. In fact, a lot of us, if you just took 100 people, on the street and ran them through a CAT scan machine, you're going to find these tiny little dots. And that can be old scar from a pneumonia, especially people who have lung damage or emphysema and things from smoking, can have some scarring and are going to have abnormal appearing lungs. So these tests are very sensitive and there can be sort of false positives with this. So generally what would happen is if they did detect something like this, you're going to get notified and called back. They might want to do additional tests such as, getting another CAT scan in 6 weeks or 3 months in the near future to see if it grows or changes or if it disappears over time, in which case that wasn't a tumor. If it does look suspicious, then they might want to get something like a PET scan, which is another type of imaging test. And it might lead to seeing a lung doctor, a pulmonologist, who might want to put a camera into the lungs and actually get a sample of the area that's in question that they're concerned about.
Okay, so you mentioned that there is a high rate of a false positive. So just if a patient gets a call telling them to come back for more testing, it may not necessarily mean that they are positive for cancer. Is that
Exactly. So it's important to recognize that we don't really diagnose cancer off of scans for the most part. There are a few exceptions, certain types of brain tumors, kidney cancer and whatnot. But as far as lung cancer goes, this is diagnosed by taking a sample of something and actually looking at it under a microscope. And just seeing a spot, again, there's many things that can mimic that and that can just disappear. Infection, you breathed in something, small bits of mucus that can collect and things if you had allergies or had a cold or something recently. So it doesn't take much, but generally speaking, they'll do this on a yearly basis to screen people for about 3 years in a row. And if everything looks good, people can sort of be discharged from that program. Other individuals, depending on risk and other things like that, might continue to get annual scans for quite a long period of time. So really depending on what they see determines what they do next.
I see. Okay, thank you. So if a patient does happen to be diagnosed with cancer after all these tests, what are some treatments that patients can expect to potentially go through?
So the main treatments for any cancer, and this holds true for lung cancer as well, are surgery, cutting it out, radiation, pointing a beam of energy to destroy something. So instead of ripping a weed out by the roots, you spray it with some herbicide or something and it shrivels up into a husk. There's still something there, but it's dead. It's not living, it's not growing or causing harm that way. And then you have medical treatments, and that can be chemotherapy, kind of like antibiotics or chemical-based drugs that kill cancer or bacteria. Chemotherapy just means chemical-based drugs that kill cancer cells, and they do it in different ways. Just like there are different classes of penicillin and other types of antibiotics, there's different types of chemo. So that's not just one thing, and they're very different. The treatments for breast cancer versus lung cancer and other things like that. So just because somebody knows somebody, a family member or a friend who had some other type of cancer and went through some type of therapy, doesn't mean that that's what would be done here. And there have been a lot of advancements in lung cancer treatment where people are living longer and doing much better, and we're saving more lives and than we ever had before. And we're building upon that success by doing more and more work in terms of precision medicine, personalized kind of medicine and approaches, and non-chemotherapy medical treatments, like a targeted pill that blocks a mutation, or an immune therapy that uses your body's own immune system to kill cancer cells. And these are all types of clinical trials that we're working on to advance that and do even better as we speak.
That's a great segue, I think, to our next speaker, Dr. Kwang Yi Wen. But last question for you, Dr. Raj. How do you generally approach cigarette smoking with your patients? And how do you start that conversation about, asking if they're interested in cutting back or quitting completely?
Yeah, I think it starts as a conversation. I tell people that my job is to provide information and help them through this process in terms of making good decisions based on good information, and not necessarily, there's a lot of information out there these days. Everybody kind of has an opinion about everything. But in this case, we try to point people towards, what does the science say? What do the exact studies say? Looking at the, literature and everything themselves. And again, empowering people to make good decision for, in terms of what's right for them. And a smoking conversation, starts the same way. That this is something that is harmful. Inhaling smoke into your lungs is never good of any type. And this is something that it's never really too late to stop. And it's amazing what happens to your lungs, you know, one day, 1 week, 1 month, and 1 year after you stop smoking. And people will tell you, and I think we have someone who can speak to that directly coming up in our batting order in a little bit.
Okay, well, thank you so much, Dr. Raj, for your insight and expertise. I'm just going to pause really quick to see if there's any Facebook questions. But if there isn't, then I will introduce our next speaker. So let me just check. Okay, so none right now. So we will move on to Dr. Wen. So Dr. Wen, I know you are an expert in lung cancer and smoking cessation research. Could you tell us a little bit about what your research focus is currently?
Sure, thank you. So my research broadly focuses on improving cancer prevention and treatment management through the use of digital health strategies and the lifestyle behavior changes. So specifically related to smoking cessation, I want to mention about our tobacco treatment program for our cancer patient that was funded by NCI around 2 years ago. And we are very fortunate to have a full-time tobacco treatment specialist, nurse practitioner provider, Nicole Basanas, and a well-trained program manager who are both very committed to help our cancer patient to reduce cigarette use. So we have seen more than 200 smoking cancer patients across Jefferson Enterprise since then. And as Dr. Sidney has mentioned, smoking cessation is not a one-day thing. We have patients being with us for more than a year, still seeing Nicole every other week. But we do have a very successful patient story, like Carolyn mentioned, that quitting smoking within 6 months. So I encourage anyone who is interested in smoking cessation to start a conversation with our programs. On research level, we also have a lot of ongoing work. For example, we just complete a retrospective study to evaluate the effect of the impact of smoking on COVID severity among our hospitalized cancer patients. That data is being published. We are also preparing a new intervention study to evaluate the effect of heart rate variability biofeedback to support our cancer patients to reduce craving via stress reduction using a wearable device, because we know from our practice that stress is a trigger for our cancer patient for craving and the relapse. So we are very excited to bring in new technology to help our cancer patient to cope with quitting.
That's awesome. Are there certain communities or populations at high risk for lung cancer, and do these communities like participate in any of your research?
Sure. So definitely smoking is by far the leading risk factor for lung cancer, as Dr. Singler already described. And the longer you smoke, the more pack a day you smoke, the greater your risk. I also want to mention that even if you don't smoke, just breathing in the smoke of others as secondhand smoking also can increase your risk of developing lung cancer, because that's also one of the motivation strategy we use when we try to help our cancer patient to quit, not only for your health, not only for benefit your cancer treatment outcome, but also good for your family, for your children too. Secondhand smoking is also a huge issue. Speaking of certain communities, racial disparity are so predominant in this space. For example, consistent data show that African-American males have the highest lung cancer incidence and mortality rate just because they are more likely to be diagnosed with advanced stage. On the other hand, our research team working with Jefferson Lung Cancer Program also just look at Pennsylvania Cancer Registry data lately in our catchment area, and I found that lung cancer disparity also very exist among Asian subgroup in our cancer centers catchment area. So we are actually starting a pilot study to connect Chinese and Korean immigrants who smoke to our lung cancer screening programs through a social media and culturally tailored smoking cessation interventions. So I think it's very important that we all together figure out a way to help underserved minority community to navigate access to the screening programs so late stage diagnosis can be prevented.
So speaking of the Asian immigrants who may participate in your research study, can you explain how patients are able to participate in clinical trials and how they get involved? And is this something, especially in the Asian community, I know from like my own work that it's kind of hard to sometimes, convince people that this is like an important thing to participate in, and what is their willingness, I guess, to participate?
Sure, sure. In general, we always want to encourage our patient to just directly ask our provider about any clinical trial opportunities. And in addition, we all know that all the trials are documented on the clinicaltrial.gov, and which has all the information about trial protocol, investigator information that patient can easily search. It actually happened, my behavior trial are listed there, and I do get email from patients across the country to ask about my study. But as Christine, you mentioned about certain minority group might have lack of access or literacy skill to access online information, search for trial, or have language or culture difference in communication with provider. I think certainly want to figure out different model. For example, the community health worker model to really navigate and connect marginalized population for them to understand the importance of clinical trial and connecting to resources and able to explain them for enrollment.
Well, thank you so much for all of the work that you're doing. I think it's very important, and it'll really benefit the surrounding communities that we serve. So thank you so much. Okay, I believe we have a question in the Facebook Live, and anyone who can speak on this should too freely. But do other respiratory diseases such as asthma or bronchitis lead to a higher risk of developing lung cancer? I'm assuming maybe Dr. Raj can answer this, or Dr. Wen.
I'm happy to jump in on that one. So again, we said really smoking by and large, I can't stress this enough, is kind of the major risk factor for lung cancers. So understanding that in terms of the rest of the pie, that kind of little bit is divided up into other things. Any illnesses that cause chronic inflammation of different portions of the body can put people at higher risk of developing certain types of cancers. We see this with people who have, say, autoimmune diseases like Sjogren's syndrome or things like that, where they have dry eyes and saliva glands are more prone to develop cancers in these areas, and other things like that. So it's not necessarily, if this is just somebody has bronchitis, they have asthma, this is not a huge risk factor. Again, they're not included in the lung screening sort of program or sort of criteria. So I don't think it's something that people should be really worrying about tremendously. But if you look, broadly enough, there probably is a subset of individuals who have more severe disease, a lot of chronic inflammation that could eventually, lead to development of a cancer over time. So while it is possible, relatively rare, but excellent question.
Thank you. And to kind of piggyback off of that, how about if people who are, constantly exposed to fragrances, like in candles, lotions, or like those wall plugins, and perfumes, do those have an increased risk, of lung cancer at all? Do you know?
So I think this is where this is how it starts. Actually, somebody asks a question like that. I ask a question like that to myself. You go to the literature, you do a search throughout, and you're like, nobody's actually looked at this. And that's where research starts. I never thought I would be doing cancer research when I was a medical student or anything else. So the short answer there is I'm not aware of any data in terms of that. I would have to look sort of more in depth myself. But Dr. Wen, I don't know if you can speak to anything there.
Yeah, I think that's a very novel question. I'm not aware of anything to be done.
No problem.
And
Yeah,
these things
'cause-
do take a long time
Right,
to
right.
develop. So we know that, like we said, you had to have smoked for 20 years. So with exposures and things like that, like vaping and sort of other questions that people ask, things that are relatively new that we didn't, weren't doing in the 80s and 90s and things like that, it can
Mhm.
take a really long time. So I might have a lot more gray in my hair by the time we have an answer to that question.
Sounds good. Well, we'll stay tuned, I guess, in a few years. Okay, we're going to move on now to Renelle, who is with the Philadelphia Department of Public Health. So to start off, I know you are a smoking cessation specialist. What would you say is the most effective way to quit smoking?
Sure. So I definitely think taking an approach which utilizes both counseling as well as nicotine replacement therapies or any other medication that have been approved for help with quitting smoking. So that might look like things like nicotine patches, gum, lozenge. The FDA has 7 medications that are currently approved and have a lot of research to show that they have been very successful with helping people quit. And they are safe and effective to use. I think that's the number one thing to really look at. In terms of doing those two things together, it's really increasing someone's likelihood of being successful in quitting smoking. And it's been shown to be 2 to 3 times more likely to actually quit and then remain tobacco free by utilizing both of those things together rather than, one by itself. Or even doing what we kind of hear like the cold turkey approach. I always get that from patients of, they're a little bit hesitant to, use a medication and really having that conversation. They are safe. There's a lot of research to show that they work. But a lot of people really come back and just say, I want to do this on my own. So I think the main thing to also remember for, smoking is really that it is a chronic health condition. And just like someone might have high blood pressure or something like that, if there is some other way to get support, to why not take advantage of that if we know that it works.
So you've mentioned like nicotine replacement therapy as a good way to effectively quit smoking, but I know, vaping is very popular nowadays. And like, what are your thoughts on vaping? And is that a helpful method to quit?
Sure. So, as a tobacco treatment specialist, my main job is to really focus on things that are, been proven to work and have been successful. And just like was mentioned earlier, there isn't a lot of research to actually show that, this has helped people reduce smoking or ultimately quit smoking. Also, a big factor that goes into that is really there is no FDA regulation being done on a lot of the nicotine products, specifically like vapes and e-cigarettes. So because no one's really monitoring any of that that's happening, a manufacturer might say, this has, low nicotine, it doesn't have nicotine, it's just a water vapor. And no one's really following up to make sure that that information is accurate, to the public. From my standpoint, we never recommend patients kind of like switching one for the other. A lot of times we do find that patients end up becoming a dual user. So they might be switching to an e-cigarette and then still continuing to smoke. One thing to really mention too with the electronic cigarettes and the vaporizers is those ultimately have a lot higher of a nicotine level than a standard cigarette or even a cigar might have. And the way that that's being used and delivered into the body is much different than a typical cigarette would be. Also, there's can be different things like different additives added into the nicotine in something like an electronic device, kind of making it become a nicotine salt rather than a free-base nicotine, which would be in a cigarette. So that's kind of allowing us to breathe those chemicals in much deeper into our lungs, which we don't know what that kind of means. As well as the harshness of the electronic tobacco product is less harsh than something like a cigarette would be. So when someone's, inhaling really deeply, they're not able to do that with a cigarette. They're kind of getting that choking or they might cough. We don't necessarily see that same thing with the electronic devices because of that different type of nicotine that's being produced.
Okay, so in a way, it's like more addictive and because it's like easier to breathe it in and
Sure. And, I
Mhm.
think with the electronic devices, there is less stigma attached with that. So we do see a
Mhm.
lot of people, using those, inside, maybe on a bus, places where we typically wouldn't see someone smoking because those laws are in effect. Just kind of that freedom to kind of use, it's really doesn't have that same odor. It doesn't have that same look. So a lot more people are using those in a lot more places that we wouldn't typically see that being done, which is ultimately, increasing how much someone is actually smoking. It's also kind of hard to measure with like the liquid nicotine. Like someone can say, I smoke a pack a day. What does that kind of look like with an electronic device? It's kind of a little bit difficult to kind of measure that and how much someone is actually going through, on a daily or weekly basis.
Right, definitely. Thank you so much for your input so far. So I know you're at the Philadelphia Department of Public Health in the tobaccos segment. What are some services and resources that you offer to patients, or do you have anything for like the community or the public as well?
Sure. So I want to say one of the biggest pushes that we really try to work with patients is utilizing the PA Quit line, and that phone number is 1-800-QUIT-NOW. And basically what that is a support with counseling that they can call that number, and any resident in Pennsylvania, some other states have some services as well. But specifically in the state of Pennsylvania, they can call that number, and it is a free, completely free service to be utilized by people that are trying to, reduce their smoking, quit their smoking. And they're able to get specific counseling sessions, as well as if they are qualified to actually get those nicotine replacement therapies that I mentioned earlier. So things like patches and different things like that will actually get mailed right to their house for free. So the state has done a really great job in, having people have access to those medications. And those are available by doing, like I mentioned before, the 1-800-QUIT-NOW phone number. And they also have online and text options as well. So if people aren't comfortable, speaking to someone directly on the phone, they have that ability to, have communication still, with technology.
Great, and you can call that line at any time of the day. And
So I want to, it's almost open 24/7, not quite. I think it's like 7 a.m. till almost 7 a.m. again. And I believe it used to be closed like one day of the year, I want to say for Christmas, but I actually think it is open 24/7 or almost 24/7 now. So it's really great to, be able to provide to patients that, the regular 9 to 5, if you're struggling with something, after hours or on a weekend or something like that, they have that flexibility to be able to utilize that, at a less likely time that they might be able to reach their provider or counselor.
Right. That's great. That's so accessible to everyone. So, and last question, do you have any upcoming programs in the community or anything like that?
So specifically, we're always kind of doing things. I know we do a lot of different events around the community, really trying to educate people, about smoking and just how harmful it can be, and utilizing that quit line as well, specifically in terms of different programs and different things like that. They kind of change throughout the year. I know one of the big ones that we have done recently has been over the television, where we've had actual people just like Carolyn who have quit smoking, and kind of really sharing their story and saying, if I can do it, that you can do it as well. And I think that really shows an empowerment to, hearing from other people that have gone through the same thing and being able to just kind of look at it to say, hey, if that person can do it, why can't I? And really take that motivation, moving forward.
Alrighty, thank you so much, Renelle, for your expertise. I'm sure if there are more questions, we will read them aloud. But for now, we will move on to our last speaker, Carolyn. So would you be able to share to us a little bit about your journey with quitting smoking and how that's been?
Sure. This is kind of weird because I'm looking at a black screen, but nonetheless, I had, I guess, the biggest blessing in my life because I've tried to quit smoking so many times. And I guess I just wasn't determined enough because I loved smoking and a cigarette. Oh my God, heaven. And so my primary doctor had just up and left and closed suddenly. And I went to a new doctor and they had done an ultrasound of my heart. And I saw the technician doing the ultrasound and I was watching his face and I kept saying, what's wrong? What's wrong? And anyway, when I left that day, Dr. Carabello said to me, Carolyn, you better quit smoking now. And so I left there and I thought, yeah, right. And I went outside of her office and I smoked a cigarette. She called me 3 days later that my hemoglobin was very, very low and I needed to get to the hospital immediately, which I did. And long story short, I met Dr. Ramirez. He came into my room one evening after I had had a transfusion and we set up an appointment for me to see him. When I went in, he had this woman in the back. She was wonderful, his assistant. And she said to me, Carolyn, would you like to quit smoking? And I said, gee, I don't know, blah, blah, blah. I went back with Dr. Ramirez. We spoke. And I thought about it the whole time. And then I went back into the office and I said, you know what? I'd love to try. She told me all about the program. And before I knew it, I got a phone call from Nicole B. I don't know, I know her last name, but I can't say it. And what a blessing. It's the first time in my life that I made up my mind I was going to quit. It was not easy. I thought about cigarettes all the time in the beginning. I started varenicline, which is a form of Chantix, which helped tremendously. I'm not going to say I didn't get urges because I sure did. You know, a couple times I wanted to punch a hole in a wall. And after time passed, I mean, she told me that I could smoke. You know, if I was smoking 12 cigarettes a day, I could go to 10 and then to 8 and then to 6. And that's what we did. And I love Nicole. She was so patient with me and so kind. And I had even told her I did not tell anyone in my family because I did not want phone calls like from my mother saying, did you smoke today? Do you know what I mean? Because it would have just put in my head, oh, I need a cigarette.
Right.
So, and for a while even, I thought, wow, this is almost saying goodbye to a best friend. And then I talked to myself and I said, you know, Carol, you must really be retarded. A best friend that's killing you, that my grandfather told me 50 years ago to quit smoking. My grandfather knew what he was talking about, an old Italian man. And so anyway, it's been going very well now. If I do get, I don't even want to say an urge for one. I don't know how to explain it. Like I may have a cup of coffee and then think about it and I'll just pop a lozenge in my mouth. The other thing Nicole had me do was to use cinnamon sticks because I felt that it was an oral fixation. It is somewhat of, besides a mental fixation, it is an oral fixation, but instead of puffing on the cinnamon sticks, I chewed at them, just little pieces at a time. And
Sure.
that helped me a great deal. I would have done anything that helped. And only one time during the entire process did I put a patch on.
Oh, wow.
So it's been
Wow.
great. And I'm so proud to say that I'm not a smoker anymore and it feels good. I have my teeth whitened, but I
That's
still drink
awesome.
coffee. So I don't know if they look brown, but
They
yeah,
look
it's
great from
great
here.
experience.
Well, yeah, that's amazing. I'm glad, that Nicole was there to be able to support you throughout your journey. I think that's really important, having that, the social support, and, not everyone has that. So I'm glad she was able to
Yeah.
help you out. What advice would you give others who are interested in quitting smoking?
You have to realize that cigarettes are not your friend, that they're so harmful, and you need to really make up your mind that you want to quit. You want to stop doing this thing that is not only horrible for you, but I even remember being outside with my friends and none of them smoke, and lighting up a cigarette and feeling very strange because not a soul outside was smoking. And I feel that most people, the majority, don't smoke anymore. And now it's gotten to a point where, like, if somebody who walks in has been smoking a cigarette, like, I can smell it and it doesn't smell good.
Mhm.
It's just, it's very hard. It's a process, but if I can do it, anybody can do it. I just turned 65, and which I still think I'm 32, but that's beside the point. After all these years, I finally wised up, and I hope that younger people would realize it before it gets to this point. I grew up in a house, mommy smoked, daddy smoked, Uncle John smoked. I was surrounded by it. And
Yeah.
then my brother and I started smoking and everybody else quit. But it was, it was the cool thing to do. And then I remember all of my aunts and uncles stopped when they were about in their 40s.
Yeah.
So
At
I'm
least,
glad I quit. I don't ever
Yeah.
want to go back to doing that again. It's disgusting. It
Yeah.
really is.
Well, I'm so glad that you were able to be successful, and that I know on average it takes people about like 7 tries at least to quit. So,
Oh, yeah. I tried quite a few times.
mhm.
And like I said, until your mind is made up, and then you have to realize, with me, it could not be cold turkey.
Yep.
It had to be the baby steps. And that's what got me there. My neighbor would say to me, but I just put them down and I never looked at them again. Well, God bless you. That does not work for me.
Yeah,
And
everyone's
so
different.
exactly. So baby steps, I got there. And I thank Nicole all the time. She says, you did all the work. I said, Nicole, I could not have done it without you. Her voice relaxed me. I can't even explain it. Like the way she spoke to me, so kind and so calm. And it just, because I get hyper, and I'm a very emotional person. I'm Italian. Can you tell by the end? But yeah,
I just want
it does
to
work.
Sorry, I just want to thank you again, Carolyn, for sharing your story, which is so powerful. And Nicole's really the star of our programs. I really appreciate you mentioned about your journey with her, and that I want to use this opportunity to encourage all the cancer patients who smoke to start a conversation with our program. As Carolyn mentioned, the baby step, I think that's our strategy, providing tangible goal. It's not quitting tomorrow, but actually providing tangible goal for our cancer patients to reduce cigarette smoking. And as mentioned, we know that cold turkey is hard. Actually data show patients who quit using cold turkey are more likely to relapse in a very short time. And we have resources here. We don't want you to do it alone. We want to help you, want to do it together. So I really want to appreciate Carolyn's stories. It's so powerful for all of us.
Thank you so much. It
Thank
really
you.
was a great experience, and I'm so glad I got through it. And I will continue to call. She still calls me, but even after time, I'll continue to call Nicole. I feel like she's family at this point.
Aw.
Right. We want to be the best friend, not a cigarette. So
Exactly.
right.
Yeah.
Exactly.
Aw. Well, I hope others on the call are inspired now from hearing Carolyn's story about quitting. So we just have a few minutes left. We have 2 questions from the audience, and then I'll ask each of our speakers to share their key message or call to action. So question 1 is, should people who were exposed to secondhand smoke regularly be screened for lung cancer? Dr. Raj or Kwame.
Yeah, for me. So again, we did talk, to just recap, somebody who smoked the equivalent of 1 pack a year for 1 pack a day, sorry, for 20 years between the ages of 50 and 80, and are either currently smoking or have quit within the last 15 years, is currently the only recommended group of individuals being screened for lung cancer. Having said that, it is important to, when I speak to my patients, we do ask about passive smoking, secondhand exposure, and things like that. And it is an absolute risk factor. So again, when people are thinking about quitting, it's not just about you, it's about your family members. What would happen if you got sick, in terms of making them sick. And, a good point was made that if you took 100 people who tried to stop and go cold turkey, majority of people are going to fail. And it shouldn't be too surprising that the more things you do, the more likely you're going to be successful in quitting. And this is Philadelphia, so I would just say trust the process. It's a continuous process, and just like the 76ers, trust the process.
And then last question. Does lung cancer have a strong genetic link to pass on to future generations like breast cancer?
Me again. So genetics plays a role in colon cancer, in breast cancer are pretty good examples. But even in those situations, it is significantly less than half of the patients that you're seeing. Based on our current understanding, it might be 15–20% if we're being generous. As we learn more and find more genes and find other things and sort of link them, those numbers might grow over time. For lung cancer, it is not necessarily your genetics at play. Genetics can play a role why somebody like George Burns smoked for 1 million years and did not end up getting lung cancer despite the repeated exposure, and why somebody else with even minimal exposure or who hasn't smoked, will develop it. So genetics plays a role, but in terms of hereditary, like passing it on through generations, not something we typically see in lung cancer. So genetic testing is not something that we do a lot of on individuals. We do genetic testing on people's tumors to personalize their treatment approach and sort of determine what things will work and won't work.
Okay, thank
And
you.
the family,
yeah.
so not being passed on, but as Carolyn mentioned,
Hmm.
it's not necessarily the genes that are being passed on as much as the habits, right? Mom smokes, dad smokes, you're getting passive smoke exposure. It's normalized and it's something that everybody in my family does, and I'm going to do it too. And
Right.
that, I think, more than anything else, is probably the common link there, more so than passing on genes. They're passing on sort of habits in a way.
The habit is generational, right, rather than the genetics. Great, well, that's it for the audience questions. So now I'll just go back around the room and ask everyone to share what you really want viewers to take home with them after our session today. So I will start off with Renelle. Would you like to share your key message?
Sure. So I would really say that, smoking or any, tobacco use in general really does impact almost every part of the body. Not just our lungs, not just our heart, and, really looking at what someone's quality of life is as well, that, smoking might be, when we think about smoking, we hear the lung cancer, we hear, heart attack, stroke, different things like that. But, the quality of life is someone able to walk up a flight of steps without getting out of breath, or play outside in the yard with their kids. And, just like Carolyn said, kind of finding what that motivation was for her, and, getting to the point where she felt like she was ready, is definitely, what we're striving for, and having that conversation. How can we get to that point? And like was mentioned earlier, it might take a couple times to get there, but as long as we keep trying and staying motivated, we can kind of take what maybe didn't work or what did work from a previous quit attempt, and we can move forward with that, knowing, what worked really well and what we might need to change up for next time, and we will eventually get there.
Thank you so much. Dr. Wen?
Sure. So it's never too late, and it's not about quitting completely. Even just reducing number of cigarettes will help. Even during treatment, that will help to improve treatment outcome. And the most important, I want to say that you don't want to do it alone. We have the resources and the support here. Please come to us. We want to help.
Thank you. Carolyn, any key messages?
I forgot to say that I can go up the steps and down the steps and up again without running out of breath, which is so great for me. I had spinal surgery, and so I quit smoking and recovering from spinal surgery, started physical therapy, and now can do it without having no breath. I breathe so much easier, and I used to develop a mucus when I would sleep that I would wake up to, cough it up. That doesn't happen anymore. So I would just say anybody who doesn't smoke, don't start. And people that do, remember baby steps. You're not alone. You can even call me. It's the best thing I ever did in my life. I just wish I hadn't waited so long, but I did it, and I'm happy.
Yeah, at least you did it now, so
Yeah.
it's always great. And Dr. Raj?
I mean,
Dr.
not to trot on what everyone else is saying here, but I would say that if you really think about the ways that cigarettes are harming you, it's easy to kind of normalize something as a habit and kind of be blind to it. But think of how it's affecting the people around you. Think about smoke exposure to your children, to your grandkids, to other people. They're expensive. Think of what you could do with that money. If you didn't smoke for a year, take out your phone, calculate how much money you spend a year on cigarettes and what a nice vacation to Tahiti costs. And you're going to find they might be fairly similar. And just think about, like, the world is a dangerous place. It's dangerous enough as it is. Why take unnecessary risks? The two things you can do to live longest statistically: wear a seatbelt, and if you smoke, quit. And if you don't, great, don't start. And I'll leave it at that.
Amazing. Well, thank you to everyone for joining us today, especially our speakers. I think we all learned so much from you, and I hope, we can go out and, be inspired by what we've heard today. Thank you so much to the audience for joining us. This is the 4th Conversations About Cancer, Recovery, Research, and Reducing Your Risk, hosted by Sidney Kimmel Cancer Center. We hope you found today's session to be helpful for you and your families. Please follow our Facebook for future live events. And if you have any suggestions or comments, please feel free to email them to us at skccoutreach@jefferson.edu.